Good afternoon, and thank you for joining us today for our webinar, Advancement in Breast Cancer Treatment, Interoperative Radiation Therapy. My name is Bradley Jobling, and I'm the Social Media Manager. After a lumpectomy, a woman must normally endure 5 to 6 weeks of radiation therapy to destroy any remaining cancer cells. But thanks to a new treatment known as Interoperative Radiation Therapy, also IORT, this lengthy follow-up can now be replaced by a single dose of concentrated radiation aimed at a smaller area of the breast. Today, our experts will give you a short presentation about this new treatment option, as well as answering some of your questions. Before we begin our presentation, I would like to quickly cover a few housekeeping issues. We are taking questions during the presentation, and to submit a question, please use the question box in your GoToWebinar control panel, normally located at the right of your screen. Be sure to select the option Send to Staff when you're sending that to make sure that we see it. We will try to answer as many questions as we can at the end of our presentation. However, if you have submitted a question that we are unable to get to, we will follow you up through email. So now I would like to welcome our guests. Today, as you can see on the screen, we have Dr. K.S. Clifford Chow, Radiologist Oncologist in Chief at New York Presbyterian Hospital, and Dr. Sheldon Feldman, Chief of the Section of Breast Surgery at New York Presbyterian Columbia University Medical Center. Now I would like to turn the presentation over to our experts.
Great. Good afternoon. We're pleased to be with you today to discuss this important innovation in breast cancer treatment, intraoperative radiation. According to the American Cancer Society, breast cancer is an extremely common problem in the United States, with 1 of 8 women who will develop breast cancer during their lifetime. We talk about treatment in terms of local therapy and systemic therapy. In terms of local therapy, patients have options. Surgical options include mastectomy, quadrantectomy, lumpectomy. Systemic therapy includes medications, which can include hormone-blocking therapy, chemotherapy, monoclonal antibodies. A very important part of the local regional management is with radiation. We're doing very well, and with treatment advances, most patients go on to live a normal, healthy life. So in terms of surgical options, a lumpectomy really means removing a small portion of the breast tissue where the tumor has been identified, with a rim of healthy tissue around it, with the goal to obtain clean margins. As part of breast conservation treatment, radiation therapy is recommended because even when clean margins are obtained, we know that it's very likely that there's microscopic cancer cells which are close to the tumor site, and radiation can eradicate that. An alternative to lumpectomy is a larger surgery called mastectomy, where all the breast tissue is removed and breast reconstruction can be performed at the same time. Conventional radiation therapy is very effective. Historically, we have treated the entire breast with radiation, and then a boost of radiation has been given to the lumpectomy site. This is well tolerated, very effective, and can typically is a daily treatment Monday through Friday, lasting between 3 to 6 weeks. This has been very effective in reducing the local recurrence risk. A very important trial, the Milan trial, which I'm going to spend a little time on, really taught us something very important. So if we see here, this yellow line is the lumpectomy scar. These are patients who were followed over a 12-year period to see the pattern of local recurrences that developed. As you can see, the vast majority of local recurrences that develop after breast conservation with lumpectomy and radiation really are at the site where the tumor initially started, with a small number of elsewhere recurrences either in the same breast or the other breast. So it began to make sense that focusing the treatment on the area where the cancer was initially is really the most important thing, rather than necessarily needing to give radiation to the entire breast. In planning for treatment for breast cancer patients, it's extremely important that you have an excellent multidisciplinary team that is composed of breast surgeon, radiation oncologist, and medical oncologist, and we communicate specifically about each patient in terms of the type of cancer that they have, the location of their cancer in the breast, and what will be the optimal approach in terms of treating that patient. So it allows us to have a very individualized, precise approach to treating each patient. So we've evolved over the years to, instead of whole breast radiation, being able to do what we call partial breast irradiation, or treating just the operative bed. And these are prior options that we've used in developing to our current technique. Option number one is called interstitial brachytherapy, where there are radiation implants that are actually these plastic tubes that are put in near the site where the lumpectomy was done. You can see on a CT scan the position of these rods that are adjacent to the tumor site where the lumpectomy was performed. And over a period of 3 to 5 days, the patients would receive radiation to that area. As you can see, it's a fairly elaborate procedure and not necessarily that patient-friendly, although it was an effective way of giving partial breast irradiation. A more recent advance was the idea of doing something called balloon brachytherapy, where a balloon was put into the lumpectomy cavity. So here you see the balloon exiting out. This is a CAT scan showing the balloon in position. And over a course of 5 days, patients would receive radiation treatment that was connected to this catheter twice a day. And after the treatment, the balloon would be removed. And these were both very effective ways of giving partial breast irradiation just to the tumor site, but fairly elaborate and not necessarily uncomplicated for the patient. So the third option, which we're talking about today, that we think is a significant advance, is the idea about being able to precisely place a radiation applicator into the site of the lumpectomy after we've removed the cancer completely, so that we can treat exactly the area that's in proximity to where the cancer was. So this is an example of a patient that we've treated who's a 55-year-old woman who was diagnosed on her mammogram with a 1 centimeter cancer. This is her ultrasound appearance of the cancer. It seems to be very well circumscribed. The diagnosis was made initially with a needle biopsy, and then we had a full discussion about options for her. She seemed to be a very good candidate for intraoperative radiation. She met with Dr. Chow preoperatively to discuss radiation plans. She then went on to have a surgical procedure, and during the surgical procedure, we did a lumpectomy to completely remove the cancer. Dr. Chow delivered a single dose of radiation to the area around where the cancer was removed, and I then did what's called an oncoplastic repair of the breast defect. And this ability to do this repair, we think, is a significant advance over the prior techniques. With the balloon brachytherapy, for example, after we would remove the balloon, there'd be a space, what we call a seroma, that often would be permanent, whereas now, after the radiation is completed, we can do a nice cosmetic repair of the defect so that the appearance of the breast is as normal as possible. So this is showing after the lumpectomy has been performed. This is the applicator in place. This is actually showing the equipment that Dr. Chow will discuss in a little more detail. And this is the technique of what we do with oncoplastic repair, is that after we've removed the problem area in the breast and after the radiation has been completed, we actually can mobilize local breast flaps. There's not an implant that's put in, and actually do a complete repair of the defect so the contour of the breast looks as normal as possible. So now I'd like to turn the presentation over to Dr. Chow, who will talk to you more about the specifics of intraoperative radiation technique.
Well, thank you, Brad, for the introduction, and then thanks, Dr. Feldman, for an excellent background about how to handle early-stage breast cancer, but also the procedure related to options to treat the local area rather than the whole big region. And this intraoperative radiation therapy certainly is a cutting edge and built on significant tens of years of knowledge. And those knowledge have, as Dr. Feldman introduced in the Milan trial, for example, now we understand to treat the local area actually certainly is one option for certain early stage patient with breast cancer. So as shown in this slide, you can see that during radiation treatment, and we work together, Dr. Feldman and I, we work together, and after removal of the tumor, and we put all the instruments together. Now, the next slide showing that the detailed description of what the machine looked like. It looks like a robotic arm. At the tip of the arm, you can see that actually you have radiation sources in there. And radiation sources actually very fine tip. And attached to this fine tip is like almost like a balloon, like a sphere. But this sphere is at a certain fixed size. And this fixed size was determined that by the area to be treated. For example, size of the tumor, amount of a tissue being removed, and so that we determine, Dr. Feldman and I would determine what is the right cavity size, and so that we use the proper applicator to treat the surface around the cavity. And once we determine, and then this next slide showing that radiation will be delivered through this robotic arm attached machine. Now, this radiation is a very low dose, even lower energy than what we usually do in a diagnostic X-ray machine. Lower energy than chest X-ray machine, lower energy than CT CAT scan. And so that the advantage of this low energy is that they can deliver radiation only in the area this balloon located. It would not go beyond the depth more than 1 centimeter. Anything beyond that is a very little dose to it. So some of the questions that you may ask, what happened when the patient in the room, you have a nurse in the room, you have other anesthesiologists in the room, you have many people in the room. But usually before machine was turned on, there's no exposure whatsoever to the people in the room. But even that when machine is turned on during treatment, only very little exposure to the remaining of the body of the patient, other than the tissue around the cavity that the tumor was located. So after treatment, usually treatment would take about 30 minutes or so, and this balloon will be removed and move away from the cavity, and Dr. Feldman will go in to close it up, clean it up, and then finish up the procedure as he described earlier. Now, the question is that is it effective treatment as compared with the conventional way of doing things? That in this slide showing that certainly there are large trial and more than 2,000 patients internationally being treated entering this trial. Half of those 2,000 patients, about 1,100-ish, are randomized to receive whole breast radiation. Half of them received this intraoperative radiotherapy called IORT. So after a certain period of time of follow-up, the result was first published in 2010, and it shows actually the efficacy, they are comparable. So a little bit detail about this is that the local recurrence means that when the tumor coming back in the breast area is very low. It's about 1%-ish in both arms, either treated with the radiation from outside or doing the IORT during surgery. And another question is that how about side effect? Actually, side effect profile is also very similar. Not enough difference to distinguish one way versus another, because the majority of the radiation being absorbed inside the breast tissue, very few leaking out into the total body, the systemically. So this study showing that as compared with the traditional radiation, the risk of side effects is very low, and the chance of tumor coming back is comparable as compared with the conventional way of doing radiation treatment. Now, another important thing is that not everybody, remember that during surgery, we only have a biopsy result. The true behavior of the tumor would not be known until maybe a week later, that when pathologists have a chance to dissect out all the detailed information about this tumor. In certain occasion, maybe a 10–15% chance, some of the tumor turn out to be more aggressive than expected. In those patients, we would have them come back for another set of discussion about the need for treat the whole breast. So in that sense, actually, we are not putting the patient at risk among those patients who really need more aggressive treatment. So who are the ideal candidates? They're usually the age more than 50, postmenopausal, because among those ladies who have those breast cancer, usually the tumor behavior is more not as aggressive as those people younger age, premenopausal. The tumor size is important. We want to be tumor smaller, and so the local therapy would make better sense. Another important thing is that you need to be unifocal. Some of the patients, the breast cancer can occur in multiple locations within the breast. In that case, this IORT would not be the best option because you really need to treat the whole breast, you know. And some other indications not included in the original trial is that we also exclude invasive lobular carcinoma, but because those tumors tend to be multifocal. And also some of the pure ductal carcinoma in situ, those patients, usually those tumors tend to have a lot of tentacles, tend to spread it out a little bit further distance out. So all those indications, we run very stringent inclusion criteria to identify those patients with better, smaller tumor size and not so aggressive behavior, and then will be a candidate for this IORT treatment. So to summarize it, it is a new evolution of treating early stage breast cancer. It's a single procedure. We work with the surgeon in the OR after lumpectomy and a removal of lymph nodes, sentinel lymph node biopsy showing that there's no evidence of spreading to other places. And then we will work with Dr. Feldman to finish out the procedure and treat the tumor bed while patient in the OR. And the advantage of doing this is that some patients, especially in our location, they travel from long distance. Sometimes they may not be able to, some family issue, some logistic issue, are not able to come into our facility for 5 days a week for 3 to 5 weeks. In those cases, and this certainly provides a very logistic alternative for breast cancer treatment. And it's very patient-centered. We consider that it's very personalized based on your need, and usually the patient very happy with the results. And so with that, I would turn the stage back to Brad.
All right. Thank you very much. And you guys can hear me, right?
Yes.
Okay, great.
Yes.
So before moving on to the question and answer session of today's program, I'd just like to let the medical professionals that are watching this, let them know about the, or learning about this, about the upcoming breast cancer management CME that's being held on January 31st. This program will review the current state of the art in breast cancer diagnosis and management, highlighting the key components of multidisciplinary treatment to include surgery, medical oncology, radiation, radiology, pathology, and psychology. For more information about this CME, please visit columbiasurgery.org/CME. And now on to the questions. We have our first question is from Deborah S. And Dr. Chow, Dr. Feldman, please feel free to chime in with any that you'd like to answer. But Deborah's question is, does IORT treatment result in systematic side effects such as fatigue, etc.?
They usually don't. As I said, that because radiation so limited to the breast tissue only, and there's pretty much no systemic effect, unlike external beam radiation. Very little radiation doses to the rest of the body, and also one-time a one-shot deal, and usually don't carry on into your daily life after surgery.
Okay. Anything you'd like to add, Dr. Feldman?
I'm just going to add to that, Brett, if I can.
Sure.
So I think that what's remarkable is that, you know, we have in the past performed lumpectomies with sentinel node biopsy and oncoplastic repair, and really these patients who receive intraoperative radiation have exactly the same post-op course as those who did not.
Okay.
You really could not tell any difference between the outcome, the way the patients feel after surgery. So really there's no perceptible change in the patient experience based upon having received radiation.
Sure. Okay. Next question. The person didn't leave their name, but the viewer would like to know, are there any other applications of this new therapy, IORT, I'm assuming, to other cancers? Would there be a potential application for this with a mastectomy?
Okay, so this not applicable to patient with a mastectomy because after removal of the breast tissue, and there's no cavity to treat. And so this is related to breast cancer treatment. And another, this robotic X-ray machine, certainly we are looking into other application to other diseases, such as a tumor in the abdomen and many other organs that may require higher radiation to certain area, while a lot of sensitive organs just right next by.
Okay.
Right. For patients who need radiation after mastectomy, they have typically more advanced disease. So they have either larger tumors, or as Dr. Chow mentioned, they may have what's called multifocal or multicentric cancer. They have may have many lymph nodes that have been involved with cancer. So some of those patients do require post-mastectomy radiation, but the technique of the radiation would not be intraoperative radiation. It would be, you know, an advanced, very, very carefully planned, simulated using advanced technology.
More comprehensive ones.
Great. Thank you. Okay, we actually have a live question that came in through our GoToWebinar panel. And again, this is for Dr. Feldman or Dr. Chow. I'm just going to read it to you. Regarding the maximum diameter of the cavity eligible for intrabeam, how do you do it in oncoplastic surgery that usually have big cavities? So I think what they're saying is, what is the maximum diameter that you can do this, and how would you do it for usually large cavities? Can you do it?
Well, the largest applicator I think that we have is a 5 centimeter applicator. So a lot of the decision about breast conservation relates to the size of the tumor relative to the size of the breast. So we can treat tumors, you know, up to, in our entry criteria, up to 2 centimeters, perhaps even a little bit larger. We want to have usually at least a 1 centimeter margin, so we can have a cavity that can be 5 centimeters. That can be treated, and if the breast size is adequate and the location of the tumor in the breast is appropriate, we can actually mobilize large tissue flaps, which we normally do when we do the repair of the defect. In this case, those tissue flaps are mobilized so that they are used to oppose the breast tissue to the applicator so that the area can be effectively treated. So still relatively large areas can be treated, I think, up to a 5 centimeter limit.
Okay. Great. Anything else, Dr. Chow, or that was you agree?
It's well said. I think the
Okay.
key thing is that the tissue around, whether have enough space to wrap around the applicator, and so that we can limit radiation doses to the cavity that in the breast.
Okay. We do have another live question that came in, and I'm going to read this. Do you wait for biopsy results showing clean margins before you start IORT? And then I think it's a two-parter. Can IORT be done with a small, for example, 1/5 sentinel node involvement?
Right. So we, during the surgery, when we do a lumpectomy, we're very careful to try to obtain clean margins during that surgery. And in our series here, 90% of the time we have clean margins with our initial surgery. So that means that 10% of the time we may not, and we may not know that during surgery. So if the patient has received intraoperative radiation and has had a lumpectomy and the margins are not clean, that would mean two things. It would mean that they may need to have an additional operation to remove more tissue, and that certainly can be done if they've already received radiation. And it also likely would mean that Dr. Chow would then treat the entire breast as well with radiation, and that the intraoperative radiation would function more as a boost, and the patient would then go on to receive, whole breast radiation.
Okay, great. Anything else?
If the sentinel node turns out to be positive, we have a decision to make in terms of, and this is where the multidisciplinary team comes in. So that would greatly impact upon the systemic therapy decision about chemotherapy potentially. It may impact upon the decision about giving whole breast radiation as well, because we know in whole breast radiation that a portion of the axilla is actually treated with the radiation, and we would tend to lean more towards offering whole breast radiation in that setting. Dr. Chow, would you agree with that?
Yeah, correct. I think that is certainly the approach that we've been taking.
Okay, great. We have another live question. I'm going to. Does the study reviewed, and I'm sure they're referring to the Milan study, but does the study reviewed have further long-term results? For instance, can you review the recurrence rates for this type of radiation versus traditional radiation?
So I think that's more about the target trial in terms of the length of follow-up.
Okay.
So I think Dr. Chow's presented, I think, the updated data from the target trial. So we now have, what, almost 5 years of data, Cliff?
Yes, it reported 2010. It's a 4 years follow-up. And I think it's very convincing in a way, because among those almost more than 1,000 women in each arm, only 5 to 6 patients actually fell locally, either by external beam radiation or by IORT. And the peak of usually the recurrence usually 3 years. So this one actually have long enough follow-up, although we also understand that the longer the better, but I think that this outcome will be continued followed.
I think one of the things we've learned as well is that patient selection is extremely important. And I think now that we see many patients who have screening mammography, we are finding many patients with very early diagnosis of breast cancer. And then in studying their biopsies, the needle biopsy reports, we can see that some of them have extremely favorable, what we call phenotypes or subtypes of breast cancer. So we are getting very good, I think, at selecting those patients who have extremely favorable outcome, and these are the ideal patients to consider for intraoperative radiation. So we think that long-term, their risk of local recurrence should be extremely small.
Okay.
Right. I think this selection is very important. I want to emphasize that this is not fit everybody. It needs to be very carefully selected, and as shown in those criteria indicator on this slide, they need to be very carefully assessed, evaluated by a team of people, medical oncology, surgeon, and radiation oncologists, and to make sure that it fit into most stringent criteria for IORT.
Great. We have two more questions. We're going a little bit over, but we're getting some good questions from our audience. One more live one. What effect does this technique have in patients with a previous augmentation with an implant? And in the cases where you don't take the implant during cancer surgery, is that something that you can answer?
Well, no, it's, I think, a very good question. So I think that we certainly have a lot of experience treating patients who develop breast cancer who've had prior implants for augmentation. And it's evolved a lot over the years. When I was in training, we were taught that actually we would do a lumpectomy, we would take out the implants, they would get radiation, and then we'd put the implants back in. Well, that certainly was unnecessary, as we learned over the years. And now we've treated many patients with traditional lumpectomy and external beam radiation for 6 weeks who've had implants. The results are very, very good. So I think if the implant is placed as it typically is under the muscle, then we can safely consider these patients for intraoperative radiation if the tumor biology is appropriate. Would you agree, Cliff?
Yes, in principle, I think they are supposed to fit into those criteria that we listed before. But also we need to consider the amount of tissue in the breast after lumpectomy. That usually patient would have an implant in their breast. Usually the tissue, the breast tissue, will be on the lesser end and will make this procedure more challenging, especially for surgeon to remove sizable tumor, the lumpectomy tissue, and followed by enough space and also enough tissue to wrap around the applicator. Is that a more challenging one, but in principle, as far as to fit into those criteria, it can be considered.
Okay, great. Our last question, which was pre-submitted by email from Jen F., says, my mom's doctor recommended IORT for her treatment. What makes me nervous about IORT is that it's a relatively new treatment. Okay, some of this may have been answered, but what do the reoccurrence rates look like in traditional versus IORT therapy? How long have previous patients been followed up for? And are there any other treatments that we can consider?
I think those are the answers we probably already elaborated in our presentation, but also other options, including those interstitial brachytherapy or balloon therapy or external beam whole breast radiation or partial breast radiation. Those are the other options that can be considered.
Right. I think this question gets at a key concept, which is now with availability of intraoperative radiation, when we see patients with early-stage breast cancer, we discuss with them surgical approaches, we discuss with them briefly about systemic therapy, but when we talk about radiation now, we know that we have many, many different options for these patients, of which intraoperative radiation is only one of them. So these patients meet with our radiation oncologist, with Dr. Chow and his team, prior to surgery, and they now have a very good understanding of the pros and cons to each of those approaches. And I think that allows them to then make a decision about their overall local treatment, which is well informed and well discussed. And I think that's a major advance.
Great. Okay, great. And you know what, Dr. Chow, Dr. Feldman, thank you so much for your time today. I'm sure most of the viewers found this to be very informative. If you'd like more information about the Herbert Irving Comprehensive Cancer Center, please call 212-851-4680 or visit the website www.hiccc.columbia.edu. You can also contact the Irving Radiation Oncology Center by calling 212-305-7077 or visit the website cumccolumbia.edu/department oncology is listed on the presentation there. And to contact New York Presbyterian Columbia University Medical Center Clinical Breast Cancer Program, please call 212-305-9676 or visit the website breastmd.org. Once again, we'd like to thank you for tuning in to our webinar, Advancement in Breast Cancer Treatment Interoperative Radiation Therapy. If we didn't, we apologize if you submitted questions that we did not have time to answer during the webinar. As we can, if we didn't, we'll try to respond to you through email. If you wanted to share this with anybody else, or if you'd like to watch this again, there'll be an archived version of this webinar available on the Herbert Irving Comprehensive Cancer Center YouTube channel, which is youtube.com/Columbia Cancer. So thank you again, Dr. Feldman, Dr. Chow. Have a healthy day, and everyone stay warm out there.
Thank you.
Thanks very much.
Bye-bye.
Bye.
Bye-bye.